All right, hello everyone, and welcome to today's Webinar Wednesday, the topic is today 60 degrees north, public health in Alaska, which is presented by 4 presenters from the Alaska Native Epidemiology Center, which is a department of the Alaska Native Tribal Health Consortium. So as in all of our different webinars, I'll be monitoring the chat throughout. The chat is open so you can interact with your fellow attendees. And then if you have questions for our presenters, please make sure to put those in the Q&A section, and our presenters will be answering those questions at the end of their presentation. So let me introduce our presenters. Our first presenter is Carla Britton. She is the lead epidemiologist for the Alaska Native Epidemiology Center, a department of the Alaska Native Tribal Health Consortium. She has over 20 years of healthcare and public health experience at state and tribal organizations in both the lower 48 and Alaska. She's a former CDC Epidemic Intelligence Service Fellow and a former National Park Service Ranger. Our second presenter is Marie Jackman, a senior program manager for the Public Health Infrastructure Program at the Alaska Native Epidemiology Center. She has worked in the Alaska public health sector for over a decade, including experience in the state and tribal public health epidemiology, as well as experience with community health centers. Marie holds a master's in public administration degree from the University of Washington and is certified in public health. Her role at the Alaska Native Epi Center, she leads public health infrastructure projects, including tribal health assessments and capacity building projects. Our third presenter is Derek Searcy, who is a public health program specialist. He supports public health programs and initiatives by conducting program evaluations, creating data collection tools, disseminating health data, and providing other technical and analytical support. He has worked in health research before moving into public health in 2020. Our final presenter today is Lowrie Ward, who is a senior epidemiologist at the Alaska Native Epidemiology Center. She manages several projects, including syndromatic surveillance. She has worked in public health since 2006 and is primarily focused on quality improvement. So with those introductions, I'd like to turn it over to Marie, and Marie can take us through our presentation today.
Okay, well, thank you so much. So hello, everyone. My name is Marie Jackman. And before we get started with our full presentation, we would just like to take a moment to do a land acknowledgement. Both my colleagues and I presenting here today work in Anchorage, Alaska, which is the traditional home of the Dena'ina people. We acknowledge the Dena'ina people on whose traditional lands we gather. We also acknowledge all Indigenous peoples of Alaska. Thank you for your past and present stewardship of the waters, plants, animals, and spiritual practices of this place. And we would also like to take a moment to welcome you to acknowledge the Indigenous peoples of the land that you might live or work on. And if you're not familiar with what groups those might be, there's actually a great resource here on the screen where you can learn more. Okay, so getting started. As I mentioned, my name is Marie Jackman. I'm joined by my colleagues Lowrie Ward, Derek Searcy, and Dr. Carla Britton. And we all work for the Alaska Native Tribal Health Consortium, which we call ANTHC for short. And you'll hear that our organization referred to as ANTHC frequently throughout this presentation. Today, we're going to cover a brief overview of Alaska and give you some context for the work that the area that we work in, describe the Alaska Tribal Health System and the role that ANTHC plays within that system, as well as provide some information on standard public health services in Alaska and how they're delivered. Okay, so I'm sure you're all aware that Alaska is the largest state in the United States by land area. And in addition to being the largest state, it's also the northernmost, westernmost, and easternmost state in the US. In fact, Alaska encompasses over 660,000 square miles in total area and is more than twice the size of Texas, and is also larger than the next 3 states combined, which would be Texas, California, and Montana. Alaska also has close to 34,000 miles of tidal shoreline, which is more than the rest of the US combined. So as you can imagine, while Alaska's vast landscape is full of mountain ranges, glaciers, waterways, and coastline, due to the sheer distance and geographic features of this area, many people in rural and remote areas of the state are far from essential services, which are frequently found in more urban areas. This is a map of the major highways and roadways in Alaska, which connects some of the major communities in Anchorage, the Mat-Su Borough, Kenai Peninsula, and Fairbanks areas. As you can see from this, and it might be a little hard to see from those black lines on the map, but much of the state is actually not connected to the Alaska road system. And in fact, 86% of Alaska's communities cannot be reached by road. In many areas of the state, the transport of both people and supplies can be difficult and expensive. And often these supplies must be transported by boat, airplane, or even snow machine, which folks from the lower 48 might call a snowmobile. And this often means that for medical care or public health services, residents must travel by air to the nearest regional hub communities, such as Fairbanks, Juneau, Bethel, or Anchorage. And rural Alaska is also where many underserved communities are located, and many of these communities often face natural disaster and significant climate change risks as well. Moving on to a little bit of demographic context. This chart just gives a quick overview of the demographic makeup of the state, which also differs from many other states. The source for this data is the 2022 census data. As you can see from this slide, the median population in Alaska is slightly younger than the US population as a whole, and also over 20% of the state's population is Alaska Native or American Indian, alone or in combination. And drilling down into these demographics a little bit more. So this pie chart in the bottom corner here represents the total population of the state. And about 75% of the state live in relatively large communities that are on the road system that I just referenced, such as Anchorage, Mat-Su, Kenai, or Fairbanks. And then if you add in Juneau, the state's capital, which technically is not accessible by the road system, but it is considered a more urban area, that makes about 80% of the state that lives in an area that's accessible by a road system, which means that about 20% of the state's residents live in very rural or remote villages. And for context, the total population of our state is 736,812. So in terms of racial demographics, because we are talking about tribal health care here, Alaska Native and American Indian population makes up about 20% of the state's population, as I referenced before, alone or in combination. And while I mentioned that about 20% of the state's population live in rural and remote areas without road access, actually almost 50% of the Alaska Native or American Indian population live in those communities, which is about 46% total. And in some remote areas of the state, actually over 96% of the population is Alaska Native or American Indian. So these rural areas do tend to have higher Alaska Native and American Indian population. The indigenous people of Alaska, this slide is really to drill home that Alaska's indigenous populations are incredibly diverse. Alaska is home to 229 federally recognized tribes. And this map, which was created with funding from the Alaska Native Language Center, as well as the University of Alaska, shows the traditional boundaries of languages and language territories. And you can see from this map, there are actually 20 indigenous languages shown here. And Alaska Native people are amazingly diverse and come from a wide array of different language groups, cultural groups, and also traditions and practices. And although there is a national boundary, a state and national boundary between Alaska and Canada, the traditional lands of indigenous peoples do not necessarily match that political boundary as well. So with that, I'll turn it over to Lowrie Ward to continue.
Thank you, Marie. All right, so we think that that context is really important as we dive into public health in Alaska, and you can probably start to see why. Like Marie said, about 20% of the folks that live in Alaska live in remote or rural areas, but about half of Alaska Native and American Indian people live in remote or rural areas. And so that makes Alaska's tribal health system really important for Alaska Native American Indian people in Alaska, but also the entire state of Alaska. So we really like this graphic because it shows the size of the lower 48, which is what we call the continental US, and it puts Alaska over it. So you just can see the breadth that we're talking about when we talk about traveling around this state for health care. And I know this is a public health presentation, but as you all have probably gathered, that ensuring equitable access public health service is a really important part of the public health that's done in Alaska. So Alaska's tribal health system is pretty unique because the Indian healthcare services in the entire area are compacted, which means the facilities receive funding from the Indian Health Service, but the tribal health facilities in Alaska are managed and owned by tribal health organizations and tribes. So that's unique across the country. We're really proud of our system, and it's pretty impressive, its breadth, as you can tell here. So we call this the hub and spoke model, and this shows how tribal healthcare services in the state. So that central dot in South Central Alaska, that's the Alaska Native Medical Center, which is a level 2 trauma center in Anchorage. And the other hubs are the regional tribal health organizational hospital facilities. And because they are tribally owned and managed, the services provided at those facilities is determined by the people in the area that run those tribes. So as you can imagine, those facilities offer different services dependent on what is needed in those areas. Those spoke communities that go around the hubs, those spoke dots, I mean, that go around the hubs, those are different smaller facilities, right? So as of the last count I could find, there are around 72 tribal health centers and around 150 community health aid clinics in those areas. And those all use different models, right? Like some facilities are only open in the summer, some are only open in the winter. Some, there'll be 4 or 5 villages served by a couple of health aides who move around. Very diverse systems depending on the needs of the people that live in those communities. And as you know from Marie's presentation, a lot of these facilities are in remote areas. So if we have a critical access hospital in one area, there isn't going to be another hospital, right? So these tribal health organization hospitals serve everyone that lives in that area, all those people that live in remote and rural Alaska, not just Alaska Native and American Indian people. So that brings us to the Alaska Native Tribal Health Consortium, which is a mouthful, and it's why we say ANTHC. That's where we all work, and it's a nonprofit tribal health organization designed to meet the specific and unique needs of Alaska Native and American Indian people living in Alaska. And we do that in partnership with tribal people and tribal health organizations across the state. Our vision statement is that Alaska Native people are the healthiest people in the world. And it's a bold statement, but it underlies all the work we do that we're going to talk about today. And we're just going to zoom in on the public health portion. And keep in mind, there's a lot of other stuff too. So we are unique. That circle in the middle of that map I showed you, the Alaska Native Medical Center, is co-managed by ANTHC and a tribal health organization that serves people living in Anchorage and surrounding areas. As I mentioned, it's a robust medical facility where folks from across the state come if they need care and it's not provided in their regions. There's also a lot of health information technology needs for these facilities across the state, as you can imagine. Several tribal health organizations share an electronic health record so that ANTHC, our organization, can provide support for public health analytics measures for federal healthcare dollars, things like that. So there's a ton of IT infrastructure that's hosted at our facility. Also, information security is really important in public health and healthcare, and so we provide a lot of that across the state. But some areas we're going to talk a little bit more about today, because they're much more public health focused, are paraprofessional training programs. So as you can imagine, all of those spoke communities don't have a doctor, don't have, an independently practicing nurse practitioner. So we have a ton of awesome programs that train paraprofessionals, train health aides or other support staff to bring healthcare out to these remote and rural areas. We also have a robust division of environmental health and engineering. We're all public health professionals on this call, so we know that things like running water, clean water make a huge difference in public health. And so ANTHC does a lot of that work that we're going to hear a little bit about later. And then community health services, wellness and prevention programming, the stuff a lot of you probably do in your public health work. We do a lot of that we're going to hear some more details about. So with that, I'm going to turn it over to Derek, who's going to start with telling us about the paraprofessional programs.
Yes, thank you, Lowrie. So I'm going to talk a little bit about some of the ways that ANTHC and its partners try to improve access to care, particularly in rural and remote locations, and in light of the numerous kind of geographic challenges that you heard about earlier here. So to improve access to care, Alaska kind of has four sort of unique provider types, and with the exception of public health nurses, which I'll talk a little bit about more later, ANTHC really plays a key role in getting these providers out to these communities who need them. So those include community health aides and community health practitioners, dental health aid therapists, behavioral health aides, and, like I mentioned, public health nurses. The goal was really to have more mid-level providers throughout Alaska, because it is very challenging, like Lowrie already mentioned, to get nurses and doctors out to these rural locations. And so these providers actually live, work, and play in these communities. And while these providers are not necessarily exclusive to Alaska, they are still pretty unique in kind of the overall provider landscape in the United States. And Alaska certainly makes more use of their skills than most other areas in the United States. So the first one I'd like to talk about are the community health aides and the community health practitioners. These providers were formally recognized and funded by Congress back in 1968, but they were actually already working in Alaska in the early 1950s. And that was in response to the TB epidemic, which was kind of ravaging Alaska for the first half of the 20th century. So even before Alaska was a state, these providers were out there providing healthcare services to rural and underserved communities. And the type of services they provide is extremely wide-ranging. They can provide all types of acute and chronic and preventative care. They can do things like physical exams. They'll provide lab work. They'll administer medications. And so the really kind of unique thing about them is that they are not licensed physicians themselves, but they do work underneath a licensed one who kind of provides their day-to-day supervision. And these guys, like I mentioned, work all throughout the state. And to enroll in this particular program, again, since the goal here is to just get more people in health careers and get more people access to care, they'll typically only require emergency trauma technician or emergency medical technician certification before they can enroll in this program. And once they do, the typical training sessions will be about it will involve 4 sessions lasting 3 to 4 weeks. Although there are different levels within the community health aid program, which will kind of determine what their scope of care is. And as their level increases, that will typically involve more training so they can provide more types of services. So because we love maps, here's another map, just kind of shows kind of the range of community health aides throughout Alaska. And this map is a little bit out of date. It's from 2016, but it does still provide a nice overview of just how spread throughout the state these providers are. You can see with the blue diamonds are actually the health aid training centers that we have in our states. We have 4 major locations, including Fairbanks, Nome, Bethel, and Anchorage. And then the red dots represent the actual communities where these community health aides live and work. And so there are approximately 550 health aides working now in over 170 communities. So again, just huge range of space that these guys are operating in. And to also kind of further emphasize their importance in the health system in Alaska, community health aides actually conduct roughly over half of all patient encounters throughout the state of Alaska. So again, these guys are really doing a ton of work to improve health throughout the state, particularly in these locations that are challenging to access and where we can't get more traditional doctors and nurses regularly. The next one I'd like to talk a little bit about are the dental health aid therapists, or DHATs. And as you can probably guess from the name, their focus of these providers is on oral health care. These first DHATs started working in Alaska in 2004 after receiving training in New Zealand. And after that, we actually started our own program here in Alaska in 2007. And so they provide a lot of types of preventative care, basic restoration services, cleanings, non-surgical extractions. But the really cool thing about this particular program is that it is done in partnership with the Iluksavik College, which is located in Utqiagvik, Alaska, which is in the far, far north. So because this is in partnership with an actual tribal college, people who graduate from this program also receive an Associates of Applied Science in Dental Therapy. And so for this particular program, the training will involve a 2-year program. The first year, they will be based in Anchorage, where they will receive kind of the more didactic classroom study, whereas in their second year, they will actually move out to Bethel and live there for a year, where they will receive more clinical training and actually start providing clinical services to patients. And again, really in keeping with the goal of these types of programs is to get more people involved in health careers and get more people access to care. The only prerequisite that prospective students have to enroll in this program is a high school diploma, which is really cool as well. So the next one I'd like to talk about then are the behavioral health aides, or BHAs. And again, you could probably guess from the name, but these guys are really focused on kind of the mental health aspects of health in the communities. So this is the newest of our paraprofessional programs. It started in 2009. And they provide a huge range of behavioral health related services, like they'll provide substance abuse treatment. They can provide community education in areas like suicide prevention. They might provide counseling services for depression or anxiety, and they can provide crisis management skills in case, or crisis management services in case anyone in the community is experiencing a crisis of some kind. The training for this one is a bit different from the other programs in that typically a tribal health organization will identify a certain level of need for behavioral health services in the community. And then someone who already works for that tribal health organization can then apply to be that behavioral health aide. And then they will start undergoing the training that is necessary to get them up to the level that was identified by the THO to provide those services. And similar to community health aides as well, these guys are not licensed clinicians themselves, but they are overseen by a master's level clinician in their day-to-day activities. And so the last one I'd like to just briefly mention here are the public health nurses, or PHNs, of Alaska. And this program is not overseen by ANTHC at all. The state of Alaska runs the public health nursing program, but we wanted to highlight them here because they are a key partner in tribal health, the tribal public health system, and especially in terms of getting access to care to these remote locations. So similar to the community health aid program, this started in 1943. So again, before the state of Alaska was officially a state. They provide a huge range of different clinical and community level services, like they'll do STI testing, various reproductive health services, well child services. And then on the community level, they can do things like provide community education, conduct community assessments, do disease investigation, and other things like that. And they also, similar to community health aides, have a huge range of communities that they visit. I think they they try to serve over 250 communities every single year. Okay. So then we've talked a bit about some of the specific providers that ANTHC tries to help promote. And I should also mention too that the way that ANTHC does this is they do not only train those providers, but they also provide them with continuing education opportunities. They help develop the training curriculum for those programs, and they also just provide general coordination support. So they're really hands-on, and they provide a lot of support to get these professionals out to the locations where they are needed most. But those providers are not the only type of public health services that ANTHC provides. So I wanted to highlight just a few of those other types of programs that we have here. The first one is something called iknowmine.org. This is hosted by the Alaska Native Tribal Health Consortium's HIV/STD program. And in Alaska, Alaska Native American Indian people have consistently seen some of the highest rates of STIs. And so this website was really made in response to that. And so there's a ton of information here, and it's primarily aimed at Alaska Native youth, but it's really open to anyone. And so it provides information on general STI information, consent, physical and spiritual health, but also it'll have resources for things like home testing kits for STIs and HIV, alongside other things like opioid overdose kits, resources where people can learn where their nearest clinician is in case they want to see them in person, as well as other resources for LGBTQ and Two-Spirit youth. Another great program we have is something called the Good Health and Wellness in Indian Country program, or GWIC. They do a lot of stuff related to improving health amongst Alaska Native American Indian people, and particularly in areas related to food access, smoking cessation, and diabetes management. And so some of the cool things that our program has done is they've helped build both hydroponic and kind of more standard gardens in rural communities where people can kind of grow healthier food and have access to it more easily. They coordinate a tobacco cessation training program aimed at providers. And they also they develop various health initiatives, both for THOs and for the state of Alaska, that are aimed at improving community health and employee health and other things like that. We also have a lot of different programs that are focused on healthy food, since that is such a concern. So, for example, we have something called the Food Distribution Program on Indian reservations, and this is just a program that provides food for Alaska Native American Indian people. But we don't also just participate in the program to provide the food. We also do advocacy work related to that, where we are currently fighting to have more traditional foods included in that program that can then be delivered to the door of eligible candidates. We also have something called the Traditional Food Sovereignty Network, and this is a newer one. But this is a bi-monthly meeting that has participation both from ANTHC folks, but also from 23 other tribal health organizations. And the goal of this meeting is to find ways to improve healthy food access, improve communication around healthy food and the benefits of it, and guide statewide food priorities. Another one that I'll just briefly mention is something called the Store Outside Your Door program. And this is just kind of an educational series where ANTHC provides information on ways that people in remote and rural locations can just go outside their own door and find harvest food from the land that they can then use in their own diets, which is really cool as well. Lastly, another one that I'll mention is we have a suicide prevention program. September is Suicide Prevention Month. So they do a lot of work related to providing suicide prevention education for communities. They provide different types of suicide prevention trainings, but they also look inward at ANTHC's own employees. So they have something like the Tell Your Heart story, which is encouraging employees to share protective factors in their own life that have helped them through mental health kind of crises or low points, and again, just how other people might find some benefit in hearing those stories and sharing that information, destigmatizing the kind of mental health. A few of the ones I'll briefly mention, just to mention them, is we have various violence prevention programs. We often have opioid overdose building and distribution events where we put together naloxone kits and then distribute them. Our colorectal cancer program provides a lot of education and resources on colorectal cancer to various communities. And we also have our injury prevention program, which provides a lot of different public health messaging related to injury prevention and offers a ton of different trainings on those as well. And then the last one I'll mention to kind of segue here is we have an entire division that is dedicated to the building and development of physical infrastructure to improve Alaska Native health, called the Division of Environmental Health and Engineering. And I'll let Marie tell you more about that.
Okay, thank you, Derek. Yeah, so as Derek mentioned, we have a Division of Environmental Health and Engineering, which we call DHE for short. And some of the main functions that DHE serves are to construct new sanitation infrastructure projects, assisting communities in maintaining systems, as well as addressing various environmental impacts. And in fact, Alaska has the lowest rate of in-home plumbing in the nation, with 2,300 plus homes over more than 30 remote communities which lack in-home plumbing. And in addition to this, hospitalization rates for pneumonia are actually 11 times higher for Alaska Native children from villages without plumbed water, and RSV rates are up to 5 times higher. In fact, 1 in 3 infants from villages without plumbed water are hospitalized annually. So as you can see, our DHE program plays a phenomenally important role in public health in Alaska. These are some of the major program areas that DHE focuses on: sanitation facilities construction, rural utility management services, community environment and health, health facilities engineering, and institutional environmental health. And of note, in typical local public health departments, a large focus of environmental health programs is food safety and sanitation inspection. However, in Alaska, these services are completely handled by the state of Alaska. In contrast, ANTHC provides many services through DHE, which are actually focused on water infrastructure construction projects. And we're not going to look at all these programs here in depth today, because honestly, we could spend an entire day or even an entire week talking about the amazing work that all of our colleagues in the DHE program do, or division do. However, we will look a little bit closer at just a couple of these different focus areas. Community environment and health. And this is a photo of Nikolsky, Alaska. And the community environment and health program's role is really to minimize health risks in the built and natural environment. Environmental health is the branch of public health that is concerned with all aspects of the natural and built environment that may affect human health. And since 1960, the Alaska Tribal Health System has provided support services to help support clean air, food, and water in Alaska Native villages. And ANTHC works with tribal partners across the state to understand communities and to identify current and emerging challenges to health systems. These services focus on capacity building, environmental monitoring, education, survey and assessments, as well as technical assistance and planning for all aspects of environmental health. Environmental health challenges that Alaska communities face include these listed on this slide, such as air quality, water security, food security and sovereignty, natural disasters, infrastructure, and housing. And of particular note is that ANTHC is also beginning to really focus on climate change and One Health approaches to public health in much of its programming as well. And finally, the ANTHC Individual Sanitation Facilities Scattered Sites Program works across Alaska to provide eligible homes with on-site sanitation services. And the program designs and constructs individual on-site water supply wells, cistern water storage systems, community sewer and water service line connections, and wastewater systems such as septic tanks and drain fields. So our DHE program is really doing the work of public health in its most foundational sense, which is actually bringing water, clean water and sanitation to communities where it currently does not exist. With that, I will hand it over to Dr. Britton to tell us more.
Thanks, Marie. And I get to talk about, of course, the subject that is most dear and nearest to our hearts, the other part of community health services, which is the Alaska Native Tribal Epidemiology Center, which is located at ANTHC. We're one of 12 tribal epicenters that are located across the United States. There's one for each of the Indian Health Service areas. And then there's one that serves the urban Indian programs. It's located in Seattle. And you can see that they're well scattered, and some of them serve lots of tribes. The tribal epicenter for the eastern area serves pretty much the eastern half of the United States. And one of the most important things that we've been talking about a lot in the tribal epicenters in the last little while is this concept of public health authority. And this is something that most of you probably may not think a whole lot about, but it's something that you use every single day when you do your jobs. It's a government body's really, it's basically your legal ability to collect data related to health and to use it to improve health. And why is it important to us? Well, you can see that the one word is government body. And so probably a lot of you actually work for local or state public health departments. So for us, because we are not a government body, we look to another source for public health authority. We look to the Indian Healthcare Improvement Act, which is the act that provides healthcare to Alaska Native and American Indian people. It was permanently reauthorized in 2010, which was great. It meant that we no longer looked for regular reauthorizations, and it formally recognized the Tribal Epicenter's Public Health Authority. So what it did for us is say that we actually also hold public health authority and the ability to collect data. It also extended tribal epicenter access to data held by the U.S. Department of Health and Human Services. So, as most of you know, the Health and Human Services includes big agencies like the CDC and the Indian Health Service, as well as some others. So that theoretically gave us broad access to data because we are not a tribe, which would be a government, and we're not a state or other recognized government. So why do we care? And why is this a big discussion in our world? Well, because at least at the Alaska Native Epidemiology Center and the rest of our tribal partners, we use data to improve health. So one of our real driving forces is our ability to access data. We look at it at the Alaska Native Epicenter as sort of falling into 4 buckets, all of which are data related. Under the Indian Healthcare Improvement Act, there are 7 core functions of the tribal epicenters, but in a sort of magical way of alchemy, we've managed to create 8 functions out of 7, and we've dropped them into 4 core buckets. Data dissemination and translation, which obviously is directly data related. Technical assistance and training, which we do a lot of training around data and data use, as well as a lot of training around some core infrastructure topics like management and grants management and communications, grants writing, and surveillance and applied studies. Out of the Alaska Native Epicenter, we are unusual in that we also are the home of the Alaska Native Tumor Registry, which is a SEER registry that is focused entirely on cancer that is diagnosed in Alaska Native and American Indian people in Alaska. But it means that we have pretty spectacular cancer data. And then finally, in disease prevention and health promotion, and of course, we use data to drive the decisions we make around those. So data is a core thing in this concept of public health authority in the last few years has been one of our biggest discussions. How do we work with data? Well, here's a few examples of some of the things we do. We produce the Alaska Native Health Status Report, which is an enormous multi-page document that I'm going to give Derek a big shout out for almost being solely responsible for updating it in its last edition. We're transitioning those kind of data displays to a more dashboard focused approach. And we just uploaded our first dashboard to our website, which we're pretty excited about because it's really going to make it a lot easier for us to update our information on a regular basis without as much effort as we were putting into it. And finally, we partner and do a lot of trainings. And just one example is the Alaska Maternal Child Health and Immunization Conference, which we partner with the state to produce every couple of years. So there's a broad variety of things that we do at the Epidemiology Center across a very, very broad spectrum of public health. But we actually could not do any of this by ourselves. We are just one of the many partners in Alaska that actually make public health work. We are partners with the state of Alaska. We partner with nonprofits, the NTHC, of course, and our tribal health organizations. Public health is definitely across our broad landscape a big partnership. And I'm going to talk about 3 examples of the partnerships that are ongoing and that provide some main public health services. And the first one we'll talk about is Healthy Alaskans 2030. The second one we'll talk about is the Alaska Behavioral Risk Factor Surveillance Systems Data Center. And then finally, we'll talk about COVID vaccine distribution at the beginning of the pandemic. So Healthy Alaskans 2030 is the state's health improvement plan. It is a state and ANTHC partnership. And at this point, both ANTHC and the Department of Health at the state have co-leads, so somebody who works full-time on this initiative. As a result of focus groups and surveys and conversations with Alaskans and various work groups. They identified 15 priority areas and 30 health objectives within those priorities, that areas that we'll be tracking over the next 10 years. We provide at ANTHC, we provide a team lead, but we also at the Epicenter provide representation on the core team and also a ton of data support as we produce that actual scorecard. So if you have time, you can cruise over to the Healthy Alaskans website and check it out. But that's a huge partnership for us and actually aligns all the objectives for health across the state, both across state and tribal organizations. And the second one I'm going to talk about is the Alaska BRFIS Data Center. The data center derived in part because although we knew that our old IBIS system was not going to be forever, we thought we had kind of an extended timeline to replace it. However, the state of Alaska experienced a pretty significant cyber attack really early in the pandemic, which brought basically their entire website down. And really basically all their data systems. We were told at that point that the IBIS program, which we used as a way of providing search tools for the BRFIS data in particular, wasn't going to ever come back. So all of a sudden we were forced into looking for an option on a really short time frame. And this is the option. This is a screenshot of the option that we came up with. It's based in our Shiny and allows you an amazing amount of search capability across the BRFIS data set. And it is a state and tribal partnership. And what we were able to do is we actually wrote a memorandum of understanding for the partnership that basically says that both the state of Alaska and the ANTHC will participate in this, and that funding would happen however it happened with whomever had any money, and that's how we would put it together. We were able to leverage some existing contractor relationships at ANTHC, which was a huge benefit to us because it allowed some really flexible development without a restrictive request for proposals where we were forced into actually doing something very specific. And so we've been able to design it pretty much as we like. And if we decide we want a different feature or to change it, we can do that really easily. So it turned out to be a really great partnership, and that will continue on to the future. But if you have a chance, cruise over to that website and have a look at that. And finally, let's talk about the COVID vaccine rollout. So the one thing we did initially was there was, of course, a lot of ANTHC and state and tribal partnerships across the pandemic response. But the vaccine task force was a unified task force that was co-led by ANTHC and the tribes and the state of Alaska. The decision was made that all vaccine allocations, both those that we received through the state of Alaska and including the Indian Health Service, and then there was an additional sort of sovereign nation supplement, would be actually received together, and that we would receive them monthly rather than weekly, which allowed us a lot more latitude in how we got the vaccines out to the communities. What were the benefits of this sort of state support with some local action? This was entirely a tribe and community-led effort, which again made it most appropriate for the communities that were being served and gave some broad flexibility into the prioritization. The prioritization was local, as was allocation and outreach. It utilized a lot of existing experience and infrastructure. We've been getting vaccines out to communities for years, and so it allowed us to use that existing experience. It also allowed for the tribal sovereignty and self-determination. That was really important. Alaska Native American and Indian people in Alaska have a lot of distrust around particularly pandemic responses, as particularly during the 1918 flu epidemic, they really struggled and suffered. So there was a lot of existing distrust that this particular approach allowed us to overcome. And finally, it was really flexible. It gave the communities a lot of opportunity to do what they needed to do to get it to happen. And so here's just a few headlines. As you can see, it was the middle of winter, as you remember, which makes it much harder for us to get things out, but vaccines are taken out by planes, snowmobiles, and boats, whatever we could, depending on where they were. And finally, here's a couple pictures from the Yukon-Kuskokwim Delta, which is out in Western Alaska. They have a road, an ice road that they can use in the winter to some of their communities. That's how they got it out. And finally, each of the community or tribal health organizations really designed their own programs and schedules. And you can see that they also provided clinics at, for example, local employers. Like one of our regions has a mine, so they provided clinics specifically out at Red Dog Mine for employees. And then also there were, you can see that in some cases they went to multiple villages in a day, and all of this really had to happen by air and was like a really big logistical challenge. And they actually had some pretty specific plans to get vaccine out. And some great messaging. Almost everybody had lots of messaging on Facebook and press releases. So lots of local effort. And finally, the flexibility allowed us to share vaccine across organizations. So there were a couple instances where, for example, they held a clinic in Juneau, but the local tribal health organization provided the vaccine for the clinic. And then in one instance too, one of our tribes or tribal groups provided vaccine to the fishing community. We were very concerned about issues related to the fact that we would have this huge group of out-of-state fisher people here. So that was a big issue. And there were actually a lot of plans written around how we were going to manage both outbreaks and vaccines within the fisheries operations. So really, what it really all comes down to is that across the Alaska's very large geographic and cultural landscape, we really couldn't do anything alone, and that this is all a result of partnerships with the state, with us, nonprofits, and tribal health organizations to provide this broad array of essential services that you've heard about. We would be happy to answer any questions if any of you have any. We're pretty pleased with the state, pretty exciting. We like what we do. So.
Yeah, it was so interesting to see some of the graphics. You know, you always know that Alaska is the largest state, but just seeing the map of Alaska on top of the 48 continent, you know, lower 48, it was just, it really hits home how big Alaska is and the challenges that you would face dealing with such a large remote area. All right, so if we have any questions, please make sure to put those in the chat and the Q&A section.
And we would actually like to remind you while you are putting your questions in that despite the way that Alaska is usually displayed on maps, we are not, in fact, an island off the coast of Baja, California. And some of the photos probably would remind you that it is, in fact, kind of colder here than we would be expected if we were an island. Yeah. Any questions?
Yeah, so we have a comment and we do have a couple questions coming in. So they just wanted, we have one comment that was, they just wanted to say how appreciative they are of how well prepared you were and the preparation you put into this presentation, that it was a very interesting presentation to see what you're doing in Alaska. And then the first question we have are there any resources you recommend for communicating with or about Alaska Natives?
I think I'm trying to think if there's really any specific resources. I mean, it's like there are a lot of resources that are produced both at the Alaska Native Tribal Health Consortium that you'll find sort of across our website and at the Epicenter's website. I think it depends on the particular topic area that you're interested in, whether they're, what you would specifically look at.
Yeah.
Yeah, we have a great communications department here at NTHC that if you had specific questions, we could connect you to. And one thing I recently did like kind of a project on that I thought was fascinating was the use of Facebook in remote and rural, predominantly Alaska Native communities and how robust it is. So if you are not yet active in like the tribal health organization Facebook pages, check those out. You can usually find out the contacts who would maybe be able to give you guidance on how to like update a flyer or edit a document around certain issues.
And if you follow their Facebook page for all of the tribal health organizations, they can pretty much fill up your Facebook feed with, and you'll almost never have anything else. So, but we do use Facebook a lot. Every rural community pretty much has its own Facebook page.
All right, our next question comes from Megan. She says, it sounds like a lot of public health efforts are somewhat decentralized. How do you mobilize and coordinate those efforts?
I think it's just what Carla talked about mostly, just really effective long-term partnerships. The state of Alaska and the Public Health Nursing Network have been around a long time. NTHC's programs have been around a long time. There's a large network of community health aides that Derek talked about that have, a ton of communication networks. So that would be my sort of answer in a nutshell. Carla, would you agree, or is there more nuance to it?
Yeah, I mean, that's a big, obviously collaborations are a really big part of it. It's kind of unusual in that a lot of the public health services that you think of, the traditional public health services, are actually really centralized at the state of Alaska and not, decentralized kind of across into local public health departments, because we really, with the exception of one, really don't have any local public health. But in terms of the other services that we provide, both, I mean, some of it, yes, it's decentralized across what the tribal health organizations decide to do and how they view their role in public health. And then, what NTHC provides and the state provides. But in all honesty, if it weren't for the fact that we collaborate a lot and chat a lot and have lots of meetings, it would be hard to get some of these things done. Unless you're DHE, which, they just go in and build a water system. So they have a really simple focus there.
Great. All right, so it doesn't look like we have any more questions today. I just want to say thank you so much for that very informative and interesting presentation about Alaska Public Health. A special thank you to Carla, Lowrie, Marie, and Derek for being here today, and all of you for attending this. We hope to see you at a future Webinar Wednesday coming up. So thank you again to our presenters and everyone for attending today.
Thanks for having us.
Yeah, thank you for having us. Excited to be here.
Thank you.